Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and most of us, well, hopefully not most, but a large number of us have been there. You're on a cold operating table. The lights are bright. Someone's asking you to count backwards, and then there's nothing. You wake up later. You're not even sure what the person's name was. The anesthesiologist is honestly one of the most important people in the room, and we almost never get to talk to them. Today I get to, again, because Dr. Huot is back with me on the show. This is your third time now. 2 more and you get the coat, like for Saturday Night Live, okay?
I want that coat.
Back in February, I had colorectal surgery to remove part of my colon because of diverticulitis. And Dr. Michael Huot was the anesthesiologist who kept me safe through the whole thing. I was super relieved that morning, doctor, when I saw you walk through to say, hey, man, I'm going to be taking care of you. I've got your back. Not that any of the other anesthesiologists in Monument Health wouldn't have been just as good, but kind of having a relationship with you in these podcasts and your TikTok fame does help knowing these sort of things, right? So I'm glad you came in here to do this again because having had a procedure done that was a major procedure, I would assume, having somebody in the room that you feel super confident with is very important. So thank you for coming back and doing this with me.
No, absolutely.
I don't usually get to talk to any of the doctors that have actually been in a room when I've had something done.
Yeah, that's right. It's you.
So you're kind of a known quantity around here, I would think. People recognize you. Like I said, you've got a TikTok following that I think a lot of doctors would either love to have or would want nothing to do with, right? So you're clearly not the guy who disappears after surgery. What made you kind of want to be visible and accessible in that way that I don't think a lot of doctors do?
I think it's partly from what you just kind of mentioned. A lot of people don't have exposure to anesthesia.
Yeah.
We come in, we keep you safe. We're actually with you for a long time, but patients don't know. They don't know all the work that goes into what we're doing because most of it you're asleep for. And our goal is to comfort you in the preoperative area and then safely see you home after the procedure. And if we've accomplished that goal, then we've been successful. And so, it's kind of nice to have a little bit more exposure so people kind of get a little bit more access to what we do as anesthesiologists and what our job entails. That morning walking in and seeing you, I probably felt the same way that you felt. It's so fun as an anesthesiologist to see someone that you know.
Oh, sure.
Because most of your patients you don't know. So it feels fun to have that kind of continuity or relationship with somebody and then to be able to take care of them.
Right.
And it's wild how life works because I don't ever really think things are chance, but it's weird how many times I walk in a room and I know somebody and it's, you have a 1 in 12 chance of having me, or it maybe is the 3rd time I've done an epidural for somebody. It's like the odds of me doing an epidural for every one of your children is horrible. It'd be 1 in 12 times, but somehow it's me the 3rd time, So I think the world has a way of kind of putting us on a certain path. And I think that's so cool. And it's cool living really in a small town because that you get to take care of people as an anesthesiologist, so it's a blessing.
Well, and cool. It seems like that really comes through with you as well. I do remember that morning getting ready to go, having you come in, and then eventually being rolled into the room, right? And the room is intimidating for a lot of people right away because stuff is happening. I mean, nobody's just standing there waiting for you, right? You're wheeled in, the nurses are there. You're one of the first faces that people see when they come in too. And that moment of trepidation, you want to take that away, I think, from the patients as soon as you can.
Yeah.
Right. Is that something important that you feel needs to be done right when you see the face of that patient on the table?
Yeah, we try to keep you calm or try to, be pleasant.
Yeah.
I understand it's intimidating. I mean, the first time I saw an OR was extremely intimidating. And then what's even weirder about it is everybody in the OR, that's their job. Mm-hmm. That's what they do day in and day out. And so there's no way to eliminate the normal banter that goes on between, whether it's people at Starbucks or McDonald's or here or the OR. People are just chatting like they do on a normal day,
right.
which I think can be a little bit weird for a patient, because you go in, there's this intimidating room, and then everyone's just kind of acting like it's a normal day, because it is a normal day for them. And so I think to be cognizant of, hey, we have, this patient's awake here, and let's try to make this as smooth as possible, get this person to sleep.
And I think it's important for people to know that. That's a great way to put it. That it's just a normal day for you. This is your job. This is like getting an order at Starbucks or going to get your oil changed somewhere. These guys, this is what they do.
Yep, right? Day in and day out, hundreds of procedures.
Right, exactly.
So, yep.
Well, if you can kind of remember my case at all, or just this is kind of in general for you, I think, in what you do. But once I got wheeled into the room and got situated and, realized that, this is pretty impressive. Seeing the robot in the corner was really cool for me. That's one of the first things I love to see, was that thing pretty soon is going to be in me, in various different ways, right? But when the patient's there, and I don't remember if it was, I don't remember if it was just was it an injected anesthesia, I would assume, for the procedure like that?
Yeah. So most of what we do, 90% plus of the time what we do, and what we did for you, move you over to the table. We hook you up to all the monitors. We want to make sure the electrical activity in your heart's good.
Right.
Your blood pressure's normal. Your oxygen saturation's all normal. We just want to make sure that your baseline is perfect before we start. So that takes a little bit of time, several minutes, 3 to 4 to 5 minutes. And that's what most people remember, is that initial part. But we're starting to log data on you as an individual, so we understand what we can give you and what we can't. And then we inject medication through your IV to get you off to sleep. Once we inject that, within 10, 15 seconds, you will be completely asleep. And so we inject that, we get you completely asleep. When we do that, you actually stop breathing. And so, there's a lot of nuance to what we do to make sure that we can breathe for you, because that can be complicating in some patients. So that's part of what we do in that initial evaluation, where we're just trying to be friendly and nice. We're actually evaluating, well, what are some of the pitfalls in this anesthetic? What could go wrong? What do I as an anesthesiologist need to be aware of and be prepared for to make sure that this is a safe anesthetic? So, we'll breathe for you for a little bit, and then once we have you really nice and deep under anesthesia, we actually put a breathing tube down into your trachea, and then we hook you up to our ventilator, and we completely take over your breathing. So in that moment, from you going into the room, we get the baseline. Within 5 or 10 minutes, we have fully taken over all functions. We can control your heart rate. We can control your blood pressure. We are breathing for you. We can tell exactly what your depth of anesthetic is. And so it's a fascinating field, because it's like a little physiology lab. We give you a little bit of this medicine, we raise your heart rate a little bit. We give you a little bit of this medicine, we can drop your heart rate. We can speed up your breathing. We can decrease your breathing. And we want to keep you in this plane of kind of not conscious, but we don't want to keep you too deep either. So we kind of keep you in this plane throughout the anesthetic, just to make sure you're nice and safe and everything's perfect. So it's a fascinating job from that perspective. But from the patient's perspective, they don't know all that's happening.
No, and you obviously don't. As you're explaining that to me, and this might be the dumbest question I could ask you. But when people hear the word you're going under, or you're going to have anesthesia, they think, I'm going to sleep. And in a sense, that's true. But you said you have to take over for their breathing, so you're not really. I mean, you're asleep. But why do you guys have to control the breathing? What happens there?
Well, so there's a lot of nuance to this, but when you're going to sleep, you're not actually sleeping. We are giving you anesthetic agents to put you under anesthesia, so it's not like a sleep state.
Right.
So it's different than that. And what's interesting about that is we know what receptors these anesthetic agents work on, but the science behind consciousness is not fully understood. So a lot of this is just, well, we know that we give you this and this is what happens, but we don't fully understand. We don't fully understand the science behind why that happens. But the reason we take out overbreathing, and sometimes we don't for certain procedures. But when you have the robot, it's going to be put in there, and they're going to be doing surgery. They have to blow up your stomach. to really inflate it like a balloon so they have room to work in there. When they do that, it pushes up on your diaphragm, and they need all your muscles to relax. So we actually, part of our anesthetic is paralyzing you. So we completely paralyze you so that all your muscles are paralyzed, so you couldn't breathe on your own, even if you wanted to. So it depends on what the procedure is, but for what we call like a laparoscopic procedure, where they need that muscle to relax, and it's going to be pushing up on your diaphragm so you really couldn't breathe very well yourself, then we put a breathing tube in and we use positive pressure ventilation to take over your breathing. And how that works is fascinating because we monitor your end tidal CO2. When you breathe out, you're breathing out CO2. And how high that level is will trigger your brain when to breathe. So even if we have you paralyzed and we have that CO2 level too high, your body might start to try to breathe. So we typically breathe you fast enough where we get that CO2 level down low enough where your body's not trying to breathe on its own anymore. So there's a lot of science that goes into it. It's absolutely fascinating how we do it. And so at the end of the case, when we reverse the paralytic and we're waking you up, we breathe really slow and we let that CO2 level rise. And at some point, all of a sudden your body's like, oh, this is too high. I need to breathe. And then you start breathing.
That's how you come out of it.
And then we turn off the vent and you start to breathe on your own. So it's fascinating how that works. It still amazes me to this day. 20 years of doing anesthesia, it still amazes me now that's what we do.
So what the time that I'm in there being operated on, then what are you doing? Are you just monitoring? Is that basically what your function is? As an anesthesiologist in that room?
Yeah, so the highest risk of anesthesia is going off to sleep because you got to take over breathing. You got to figure out how to do that. And if you have trouble doing that, you have to figure that out extremely fast. That's where anesthesia is people say it's 5% terror, 95% boredom. If you're a family medicine doctor and you go into the clinic and you say, hey, I got a problem, doc, he can ask his friends or look it up on ChatGPT or Google. If you have a problem in the OR, you literally have minutes to be able to fix it. You don't have time to look on your phone. You have to know what to do immediately. So going to sleep and waking up are the two most dangerous things. There's other procedures we do, like if you're having a heart surgery, when we go on the bypass machine, that's dangerous. So there's other nuances to other procedures, but those are the two most dangerous. And then the plane of anesthesia in between is just where we're adjusting your anesthetic level. Your blood pressure goes up, or your heart rate's starting to go up, and we think, oh, you're a little bit light. We might turn the gas up a little bit and turn it back down and adjust your breathing up or adjust it down. And who's actually in the room with you can vary depending on where you're at. At our hospital, we do a team model. So I work with four nurse anesthetists. So the nurse anesthetist is in the room monitoring the anesthesia the whole time. I'm not actually in the room the whole time. I'm there when you go to sleep. I'm there, I check in multiple times during the case. I'm there if there's a problem or a complication, and I'm there at the end. But the nurse anesthetist is in the room kind of adjusting that anesthetic level while you're going through your operation.
Are you going to other like cases or other procedures then in that kind of in between? Do you kind of bounce back and forth?
Yeah, we're bouncing back and forth. So we'll be in supervising more than just one OR at a time. Yep.
Okay. Yep. You talk about waking up, right? And I know that's a big fear that I think a lot of people have when they go under anesthesia. So how do you kind of have that conversation with patients, or what would you like them to know? If that's because none of the fears they have are really irrational. Everybody's going to be scared of something like that because it's a surgery.
Yeah.
How do you have that conversation with them? Like, look, you're going to be okay. The odds of you waking up in the middle of this are, I would assume, pretty low. Yeah,
very low. We have a lot of our modern medications and our ability to see how asleep somebody is. Waking up in the middle of a case is it's something that's extremely rare. And I'd say that is kind of a fear of people. And then people also are like, well, make sure you wake me up at the end of the case, And we always joke, well, that's what we get. We actually get paid to wake you back up. That's where the money comes in.
I don't get the check until you're awake.
Until you're awake. And we do hundreds of anesthetics. Literally, we're supervising literally thousands of anesthetics a year. So our depth of knowledge and our experience and our main job as anesthesiologists is to know when someone's, starts, looking like they're not doing good, to be able to bring them back up and make sure they're doing good. So we are extremely good at taking care of patients. And if there's complications, we're extremely good at modifying those complications. One cool thing about anesthesia is prior to like the 1980s, anesthesia wasn't considered very safe. So anesthesiologists as a specialty, they decided to do a lot of quality improvement. They looked at case reports and they just made drastic changes year over year. And there has been no specialty that has outperformed anesthesia in what they've done in safety in the last 40 years. So anesthesia has become incredibly safe, and it's through the work of people working in anesthesia, constantly looking at what we're doing, constantly modifying it, constantly making it better, to the point where now we would consider anesthesia for most people is safer than just driving in the car. So
I've seen the drivers around here. Yes, that's 100% accurate.
And we risk stratify too. I mean, there's no doubt we do high risk, very high risk things. If in Western South Dakota, there's anesthesia done all over the place. But if you're in a complex case, or if there's a high risk to it, they come to Monument Health Main Hospital because there's nowhere else, other than the Sioux Falls area that has that kind level of anesthesia expertise. And we're honest with patients. I mean, if somebody is very high risk or it's a very, touch and go procedure, I mean, we would say that to the patient before. So, I think part of being a good anesthesiologist is, being comforting, knowing that you are getting world-class care right here in South Dakota, but at the same time being honest about what that looks like. I mean, if somebody comes in for a big trauma case and it's going to be extremely difficult, I think the patients deserve to kind of know,
right,
what am I thinking too?
Right.
Even though at the same time we are going to really take good care of you.
What is in your opinion, what is one of the most difficult cases or difficult procedures that's done? Do you have any that kind of come to mind that you're really, I mean, not that you're not dialed in for every single one, but one where you're like, all right, got to be perfect?
So probably the hardest ones that we do are trauma cases, I'd say.
Oh, sure.
Because we have planning. Like when you came in, we knew you were coming in.
Yeah.
I was able to look through all of your medical history. I was able to talk with you, understand every single pitfall, and really examine with the team, okay, what do we need to watch out for here? How do we make this anesthetic perfect? When we have a trauma come in, it's somebody, got in a car wreck on 8th Street, and all this, we know nothing about that patient. They might not even be conscious. They might have lost half their blood volume. They roll into the emergency room, and we get a trauma page alerting, hey, there's a trauma in the ER. We go visit, see the patient, and the surgeon might say, this person is going to die unless we go to the operating room right now. And so all of a sudden you call the team, hey, get the OR ready. We're coming right now. We don't know anything. We don't even know the patient's blood type, and we're rolling back to the room. And we save people's lives every single week. Like you'd be surprised how many times we probably have more than one trauma alert every single day. And our teams save people's lives every single day.
Really?
Yes, because we're covering all of Western South Dakota.
That's true.
Parts of Nebraska, Colorado, Wyoming, North Dakota. If a major thing happens, people are flying in on the helicopter. And so even though, you go out in town, you're looking around, things look normal, at the hospital there's often a trauma going on where doctors are, everyone, the whole team's practicing at the top of their game to save someone's life. And I think those are the hardest cases because you don't really have time to plan. You got to be quick on your feet. And it really is moments can be the difference between life or death for people. And so that's kind of the hardest part, I'd say, about being an anesthesiologist.
Well, there has to be conditions that people have that come in. I know we talked about this once before, and I'm just so interested in this condition of malignant hyperthermia, which some people have, which can be extremely, my wife and son have malignant hyperthermia. So if they come into in our OR or have to have a procedure done, anesthesia can be dangerous for them, correct?
Yeah, it could be if the team doesn't know.
Right.
There's a couple different agents that you have to avoid if somebody has malignant hyperthermia. There's really just two, and as long as we know, then there's essentially no risk of them having malignant hyperthermia.
So that it used to be a bigger deal, I'm assuming.
Well, it used to be a bigger deal, I suppose, when people didn't know. It's still a big deal. But if we know that somebody is susceptible to it, we absolutely can make them have 100% safe anesthetic. Right. Now, in a trauma situation, that's where it gets a little hairy because we don't know. And I have had that happened to me in my career one time where, the family rushed in and was like, hey, that person had, they are susceptible to malignant hyperthermia. It's like, oh man, I'm glad you came in and told us that because, when you have a trauma patient, they can't talk to you. That's probably the one time when it's kind of, you really need to know that information.
What is malignant hyperthermia? I mean, as a condition?
So malignant hyperthermia is essentially you react to anesthetic vapors or non-depolarizing muscle relaxants, and it can just kind of uncouple this process in your body that makes your blood or your temperature become extremely high. And so we can treat that with something called dantrolene. So we can treat malignant hyperthermia, but if somebody gets it, it's extremely dangerous. I mean, it is probably one of the bigger medical emergencies that happens with anesthesia. We normally, most people and we keep you asleep with anesthetic vapor, things like sevoflurane, desflurane. If somebody has that, we keep them asleep with propofol instead. So we ramp up the propofol through the IV to a level where we have them under a general anesthetic and we avoid the vapors. So if you avoid those two agents, the vapors or the depolarizing muscle relaxants, then you won't get that process won't happen for the patient. So,
well, is it true too that the rooms have to be taken care? I mean, because of the vapors can stick around for a while, and they even have to be, or is that a thing that people worry about anymore?
So that's kind of a thing of the past.
Is it? Okay.
In the past, you used to have. When we have you on the ventilator and we have anesthetic vapor. So this is cool because I'm a chemistry major. So there's a lot of chemistry in anesthesia, but you basically have a flow going over a volatile vapor. It picks up this and you deliver it through a percentage into the lungs. It goes to the brain, puts the person asleep, goes throughout their body, then they blow it out. Well, before our scavenging systems used to push some of that vapor into the room. Now that's not the case. Now we have that hooked up to scavenging systems that pushes that vapor out the roof of the hospital.
So you're not kidding with how far technology and this has come with anesthesia.
Yeah.
I mean, it's come
a long ways.
Boy.
I mean, it's very fine-tuned. Like the technology that we have now and the medications we have and what we're doing, is very fine-tuned. So back in the day when it used to scavenge in the room, you did have to be a little bit careful. Somebody potentially with malignant hyperthermia could, be breathing in some of the vapor. But now our systems are pretty well dialed in that I'd say you don't have to worry about that.
How is AI showing up for you guys in anesthesiology? Is it?
It is showing up in some of the decision support. There's an AI tool that just came out about 12 months ago where you essentially can tell it the history of a patient and it will then give you all of the anesthetic considerations for that patient. And so we've kind of played with that, it's interesting. One of them, I asked about a patient just me and my partner were playing around with it, and it didn't bring up one very important consideration with this disease process. AI missed it. And I was like, hey, wait. It was Dr. Feehan. I don't know if you know him, but I was like, hey, this AI didn't say that this was an issue. That's an issue, isn't it? He's like, oh, absolutely it is. So it's not perfect. It still misses things.
Right.
I think AI is going to play a major role in healthcare in the future. There's no doubt about it. I mean, I've been actually saying this for a couple of years, and if I said this 2 or 3 years ago, people would be like, "No, that's not going to be the case." AI has no empathy. While not true, there's a study that showed patients actually felt like AI was more empathetic to their problems than humans.
Right.
And I can
Which
see how
sad,
that is because our dog unfortunately passed away about 6 months ago, and I was asking AI, all these things, the symptoms, because I was just playing around with it. And the first thing AI said was like, "Oh, I'm sorry that your dog passed away. That's really." I was like, "Oh, that kind of made me feel better," even though it was AI.
Right, exactly.
So AI is coming in strong. I think AI's limitation for anesthesia is you kind of still have to have a human because computers will always be faulty. They'll freeze or whatnot. That might be fine in like a family medicine visit while you're getting treated for hypertension, because it's like, oh, it froze, reboot the computer.
Yeah.
If that happens in the OR, a person could die.
Right.
So like you have to have human interface that it has to be so reliable it can't even freeze for 30 seconds, or there's going to be a problem. So maybe if AI ever got to that point, it would kind of impact anesthesia. But there's no doubt about it. AI is impacting, I think, pretty much every profession. And,
it's everywhere.
We're part of the Mayo Clinic Care Network. Their goal is to implement 1,000 AI processes within their hospital in the next year at the Mayo Clinic. So pretty much every specialty is implementing some kind of AI quality decision support system. So I think it'll really make things better for healthcare for sure.
And when you're going to just your family doctor now, you see the signs on the wall that say, this may be recorded to help. And I'm assuming that AI is taking what you're talking about and just paperwork alone, I think, could be a huge help for what you guys do.
Yeah,
right?
and we track that. This isn't part of my anesthesia job, but this is part of, I am the executive medical director for quality and safety for not just this hospital, but the whole system. And we track that, how we can tell when physicians and providers are doing chart work. And so we can tell when they're doing chart work in the evening. So a lot of physicians, providers see patients all day. They'd go home, put their jammies on, and then they'd finish their charts. Yeah. Well, since we've implemented this AI program that essentially listens to the conversation and dictates a note, they haven't had to do that and the notes have been much more accurate because things are caught in there, and it's just incredible that AI can do that.
Yes.
The next I think step is AI is going to start to listen, but then it's going to start to suggest. It's going to start to be like, well, doctor, maybe you need to think about this diagnosis too, or maybe you need to run this test too. And if you think about what AI does, how it processes thousands or millions of interactions, and it can hone in, and be more accurate, than physicians in a lot of ways, I think it'll really make care safer, and it'll really boost quality for everybody.
Absolutely.
Yeah. So I'm excited about that.
Well, you also are the medical director at the pain management clinic here at Monument Health too.
Yes.
How does that roll into what you do as an anesthesiologist?
Yeah, it's weird that pain and anesthesia are linked because they are completely opposite. Yes. Anesthesia is like high acuity, and pain is not. Pain's, managing chronic problems. And so it's weird that the two are linked. I think the two are linked because of the interventional side. On anesthesia, we do a lot of procedures, nerve blocks, we're doing epidurals. And so kind of part of the core of pain medicine was a lot of interventions or intervention heavy. And so anesthesiologists, way back when pain medicine kind of started, were just positioned well to be able to do those same things. But they're two extremely gratifying specialties, totally opposite. But to help, I had a lady the other day tell me in the pain clinic, I went home, I came out of the bedroom, older lady, stood up, twirled around, and my husband said, "Oh yeah, your outfit looks great, honey." Just like what a husband should say.
Yes.
And she's like, "I'm not showing you my outfit. I'm showing you I can stand up straight for the first time in 10 years, and I'm not having back pain." So, so that kind of story, it's just like, man,
those
pain,
have to feel great.
Yeah. Oh yeah. Pain just can pull the rug out from under people's lives, and it can be so, but then it's beautiful to take care of people like you too, because life is just human interactions.
It is. Totally.
Somebody's faced with something they have to go through, and nobody wants to have surgery.
Right.
Nobody. It's scary. So it's fun to also be there. Be involved.
To hear people afterwards. I'm assuming you don't get a lot of that. Because most people are like, oh, thank God the doctor was there, and obviously, thank God the doctor was there.
Yeah.
Right. They're the ones, but the crew in the room at that point all should get a thank you, because everybody kept you alive and made sure the surgery worked.
Oh, absolutely.
Right?
And that crew is so crucial. From if you talk about surgeons, we can tell how long it takes them to operate based on who their scrub tech is and what their experience level is, just the person handing instruments. So it really is, it's like a well-oiled machine. Everyone in there plays a crucial role to having it be successful. And I'd say even from a bigger, step back, 20,000 foot view, quality at our hospital, and the reason we've been able to make such progress in quality really comes from an all-out dedication from the valet to the CEO saying this is important, and everybody working as teams. But certainly the OR is one spot where you definitely see that teamwork, just firsthand. It's happening in real time, to make sure that every patient coming through has a safe and successful experience.
Well, and just thinking back to that day, again, like we mentioned earlier, going in and after you had said, that it's just like their normal work day. When I'm thinking about it, I'm like, that's exactly how it felt. Because at no point did you feel, or me specifically laying there, at no point after I got in there did I feel like, well, I don't know if this is going to work. I don't know. You know what I mean? It was like, I'm going to wake up here in a little bit, and I'm being a little bit of pain. Obviously, I've been cut into, but I'm not gonna have any of these worries or fears about what just happened in that room.
Yep.
Well, I wanted to get to one question because I was reading something before you came in, and you mentioned it just briefly earlier. That researchers now are using anesthesia to study consciousness itself. They're trying to figure out what makes us aware as human beings. Have you read anything about this, or have you looked into this at all?
I mean, I haven't, to be fair, I haven't looked at the current, the most recent research into it, but part of anesthesia training does kind of delve into that quite a bit. What is consciousness, which is kind of a fascinating, it's a fascinating thing. What is consciousness? When is someone conscious or unconscious or aware or not aware? And under anesthesia, it's absolutely fascinating because there's lots of things we can do. If we just put you under anesthesia, like a general anesthetic, we're just using gas and you're completely unaware, unconscious, and I pinch you really hard, your heart rate's going to go up and your blood pressure is going to go up. So somewhere your body's still processing like what we call nociceptive insults. So you're still processing pain, but you're not aware of it. And so anesthesia, we use lots of different medications. We use pain medications then to kind of blunt that response because your body still is sensing pain on some level, even though you're not conscious. And that's always fascinated me. That's fascinated me. And the other thing, I mean, it's just wild. And then we're using paralytics. If we only used paralytics, we could completely paralyze someone and have them be wide awake.
Yeah. Oh, and I think that's what terrifies people.
And I think that is what terrifies people. That's why we have so many different checks and balances to make sure that never happens. But it's fascinating because we're using different medications that have very targeted processes and we're looking for specific responses and it's kind of a cocktail really what we're using. But the consciousness component is kind of interesting, and it's the anesthetic gas that's really all that's doing for us is taking away the consciousness. And again, they're not totally sure. And they kind of found that out by people would just test it on themselves. I mean, people in the 1800s were wild. It's like, well, what's this? Let's give it a try. Right. Try it out. And then
now cut me. All right, what happened?
Yeah. And it was found out, like I think in the 1840s, which is wild, like 150 years ago, they were messing with ether and found out, oh man, I just took this and I passed out and I woke back up. And so the first demonstration of that was actually, I think, 1846 in Boston, I think for a dental procedure, in the ether dome, where somebody, had dentistry and they were asleep for it, which is fascinating.
Can you imagine that guy was like, I get to be out. I don't have to experience this awake. Exactly. This is the best day ever.
Yeah, exactly. Exactly.
I've also, one thing I've seen or read, and this could be true or not, but apparently you can't dream when you're under anesthesia. I don't know if that's true or not, but I thought, to me, that was super interesting.
I'd say it depends. It depends on what level of anesthesia you're at.
Sure, right.
And what we're doing. I mean, it's pretty common, like if we're doing like a propofol sedation, it's pretty common that people will kind of wake up and have dreams.
Really?
Yeah. If people are under like a full-blown general anesthetic, I'd say most of those people don't wake up with dreams, and in fact, it's kind of wild because a lot of times someone might be saying something when they fall asleep.
Yeah.
And then they have this 4-hour procedure and they wake up and finish their sentence, which blows my mind. That's wild.
And again, that goes
it's
back
almost
to that.
like we don't totally understand the basic science behind it, but like we literally pause the person's brain.
Right.
And then 4 hours later unpaused it and they finish their sentence. Like that, when that happens, I'm blown away every time.
Well, we have to at some point, because again, you understand the mechanics of anesthesia, but not exactly how it works, and not exactly how it makes you go out and do the things that it does. I just have to assume we'll catch up to that at some point. We'll figure this out as to why it does what it does.
AI will probably figure it out.
Well,
I'm just kidding.
Maybe we'll get to it. I don't know. So far, it's working. Don't worry about it. Don't ask any questions at this point. Well, is there anything that you wish patients would ask you before surgery that nobody ever does?
Not necessarily. I think the one thing is whatever is on your mind, just ask it.
Yeah.
Sometimes you can tell someone's a little bit hesitant. It's like, no, what's your question? Several nights ago, I had a patient, a younger patient, and I wasn't busy, but I could tell like something was lingering. So I just sat down and we were chatting for a little bit, and then sure enough, 15 questions came out. All the fears came out. And it's like, oh, yeah, talk about it. And I think that person felt a lot better just to have a conversation about it, I'd say us as anesthesiologists are all incredibly chill people.
Yeah.
There's...
Well, absolutely.
I know maybe it feels intimidating to talk to the doctor or to an anesthesiologist you've never met before. But, our main goal is to make sure you're comfortable. That's why we see you in pre-op. What we're trying to make sure we have a safe anesthetic plan, but it's vitally important to us also that you're comfortable. So, if there's questions, just ask them. We don't think any question is a dumb question. We're happy to answer any questions.
Do you feel you get enough time with the people? Do you feel like you get to, or are there just too many cases sometimes?
Oh no, we definitely get enough time.
Okay,
I think our model is one where it's pretty nice actually, because we're never really under the pressure of, we got to see this person and we got to go in 5 minutes. We're always planning. We know when cases are booked. We know how much time we have, and so we really can slow down and spend more time when we need to. And some people don't want that. Some people are like, don't tell me anymore. Let's just go. So
make me asleep.
Yeah, so we can speed up too. So yeah, we can take our foot on and off the gas pedal. But it's very rewarding, and it's very rewarding, I think, to be involved in people's lives in that way.
Well, and you can tell, and I've made reference earlier to your TikTok account that you have too, which is very popular. Lots of people watch your TikToks. I follow you as well because you're not just talking about this, and it gives insight into who you are as a person a little bit, which I think it goes so far to people that need to have procedures done and to need to know that if they're going into the hospital here at Monument, I've watched this guy on TikTok and he does what I do. This is funny. And, he's told some touching stories and he does this with his family and he's got a new puppy. And you just feel much more confident going in in any job, honestly, if you know that person a little bit more. Do you ever encourage other doctors or people you work with to be like, you guys need to do this?
No, I've not ever encouraged other doctors to do it, but I will say it's multiple times a week. I'll walk into a room and someone will be like, oh my gosh, I'm so glad it's you. I follow you on TikTok. It's kind of funny. Or they'll special request me for epidurals or cases or whatever. I feel bad. I can't always fulfill those, because our schedule is the way that they are. But I do think it is kind of cool. That part of it is very cool because it's like, I don't get to know patients and they don't know me before I see them. So if someone happens to follow me and I happen to be their anesthesiologist, it is nice because it's like, okay, well, you know me.
The connection
let
is
me
there
try
then.
to get to know you then real quick before we go back. So I think that, I've gotten a lot of positive feedback about patients really liking that. It's kind of funny.
Well, I like them because yours aren't super long either. I like to keep the short ones in there to watch.
Yeah, that's an anesthesiologist's attention span.
There it goes.
Squirrel. That's funny.
Well, I don't know if I'm afraid to do this, but you said coming in that you had questions for me.
Oh yeah, I do actually. Yes, I
don't know.
I'm going to open my book here.
I don't know how this is going to go.
This is my third time on here.
Yes, it is.
And I thought, it's cool what you do. You get to talk with doctors and
I do. It's a blast.
It's a cool thing that you're doing. But I've kind of observed and watched, and I thought, you know what? Mark he's never in the hot seat. So now I'm going to put you in the hot seat.
All right.
So I was just curious, coming in, what initially inspired you to start doing this, to start to interview,
doing this podcast? Okay. What's really funny about this is I remember, because this will be episode 191 or 92. So we're almost at 200 episodes with this podcast.
Oh, wow. That's
which
a lot.
In the podcast world is insane.
Yeah.
Most people don't get past 10.
Oh, yeah.
And then they're done. But we, of course, teamed up with Monument Health. We are a marketing agency here, right? Mm-hmm. And so we said, well, hey, how can we make your product more accessible? That's the goal. That's what we're hoping to do, to make people understand that Monument Health is a great facility here in our region, because kind of for the island that we're in. Mm-hmm. And one of the first, I don't even remember who first proposed it, but one of the questions was, well, we should do a podcast with the doctors. And I was in the room when the meeting happened, and as soon as it came out, all eyes turned to me. And I thought, well, this is going to be something I'm going to be asked to do.
You're the man for the
yes,
job.
I will be. Because I think it just became down to I'm curious. I'm ridiculously curious about things. And I love to know what you guys do because of the specialty and because of the sheer amount of school and dedication that it takes to do this.
Yeah.
There's very, very few jobs that are like that.
Oh, yeah.
And so to me, getting to know that inner working in your brain, that is what I love more than anything. So that's why I decided to do this. I'm like, hell yeah, I absolutely want to talk to these guys.
You're fantastic at it.
Well,
so you kind of mentioned that you're curious. And
Yes.
so in that curiosity, what have you learned that's kind of changed your perspective on healthcare? You know, after talking to 200 different doctors, there must be kind of things that have changed the way that just you yourself view healthcare.
That's a super easy question to answer. It's because almost to a doctor that I have spoken with is the passion that every single one of them has. Mm-hmm. Usually you'll talk to most people in any given field, and yes, they enjoy what they do, they like it, but there's just a spark. There's something in their eye that clicks when you start talking about what they do, and there's a lot of instances I could turn off my microphone and 30 minutes later they'd still be talking about that one thing. And after they're done, you realize there's something inside of you that draws you to this field, I think. I've asked so many people, well, how did it start for you? Did you have family members? Did you have people that were, that kind of pushed you to it because you felt like you had to? Mm-hmm. And most of them were like, no, sometimes I didn't even know. And all of a sudden, this thing happens, and I'm in the greatest job I've ever had.
Oh, that's cool that you noticed that, because I do think that medicine, being a physician should be a calling,
Yes.
I mean, you get to be in a sacred space with patients. So it's cool to hear you say that you noticed that amongst physicians.
It was almost, yeah.
Because I think, and that's who we're trying to find at Monument Health. We tell physicians, hey, this place is not for everybody. We're really looking for people that are passionate about it and that kind of want to, be part of our culture of caring for patients and really doing a good job. So what's the most unexpected or surprising thing that you've had during an interview? There must be multiple ones during the 200, but what's the funniest or the
I don't know
craziest?
if I can talk about it, honestly, because it happened with one of the doctors that is why can't I think of his name right now? There's been a whole bunch of doctors, but it was a plastic surgeon, one of the plastic surgeons that we've had.
Yeah,
and. Yeah, unfortunately, I'll have to tell you when the mic's off.
Okay, all right, good.
But it's
so there has been moments.
There has been moments, yes.
Where you're over there wide-eyed.
And again, I mean, none of it, of course, is none of it breaks any rules of the things that they're telling me. It's just procedures or things that have stood out to them specifically. Mm-hmm. But again, it does go back to every time they're telling a story of something that is kind of surprising. It always comes from. Of someone coming up to you, like you said, with the woman you helped with pain, of like, I can't believe you fixed this. I can't believe now I can do this thing again, right? And every time I hear that, I'm like, God, that's just got to make you guys feel like superheroes, because you're just doing your job, you're passionate about, and it's unfortunate that maybe you don't get to hear that final product as often as you should.
Oh, that's true. I never thought of that.
So yeah, that could be.
I just got two more questions for you. So you are incredibly comfortable to talk to. I remember the first time coming on here, I was like asking my wife, what do you think he's going to ask me? Here, quiz me some questions. And then I came and you didn't ask any quiz questions, but somehow we got through the half hour.
Yeah, exactly.
And it seemed like it passed in no time. So do you have some tricks to this, or is it just who you've always been?
It's not who I've always been, honestly. It took me a long time to get comfortable with asking these kind of questions, or just doing interviews in general. Because doing an interview is not easy, because you want to make it interesting. Mm-hmm. I want people listening to this podcast to be like, oh, that was, the questions were cool, the responses were great, the doctors sounded like they're super intelligent, which of course they are, super knowledgeable. But there's a guy that I have a mentor in this business who he has no idea who I am. But in the business of radio and broadcasting and podcasting, you listen to a lot of other people. And there's one guy in particular that I've listened to since the 90s. He was a late night radio guy for a long time in Minneapolis, and now he's grown into podcasting, which he does quite a bit of. And he is just the best interviewer I have ever heard. Somebody will come in with a book that, hey, we want you to interview this guy. He sits down, reads the book twice, and then goes through the questions. And then when he's talking to these people, you can tell he's paid attention.
Oh,
and so then the responses that he gets are responses you wouldn't normally hear from. So what do you do for a living? So where do you, those boring questions that some interviewers will do. So that's where it comes from. It's just this guy has changed my interviewing life, honestly, because I try to emulate everything he does.
Oh, that's cool.
So I've looked into your background and watched your TikToks a ton. So at least I kind of so I don't feel stupid coming in and asking a question that you're like, well, you should have known that. That's dumb, right? That sort of deal. So that's where that comes from. Yeah.
Oh, well, you're very good at it. And this is very difficult, by the way, me trying to read my questions, listen to what you're saying, but think about what my next question is.
Right.
I'm like, dang, it's tricky. Easier. I'd rather do anesthesia than this. I'd rather keep someone alive. All right, so last question. This one, there's a lot riding on this.
Okay.
You better choose this correctly.
All right.
But after 200 podcasts, you must have thought, what specialty would you be if you were going to go into medicine? So what would that be? And it better be anesthesia. I'm not ever coming on here again.
The thing is you just after this conversation, because we generally talked about anesthesia the first time, and then we talked more about you were of course the
pain and quality.
Pain management quality, and I think anesthesiology might be the one I would pick because of the known unknowns in it, you talked about.
And they're the coolest doctors out there.
Well, you know what? No, so far, every single one that I've talked to, and like you said earlier, you guys are just chill, right?
That
You're
is the
easy to have.
personality.
Not that a lot of the people I've talked to haven't been easy to have a conversation with, but you guys have. The rest of the doctors, please don't take this wrong. Listening to this. You guys have a ton of personality, right? And that's so vitally important when you're the last face somebody sees generally before they go under. That has to be there, that trust. So I would say either anesthesiologist or, I don't know. Maybe dermatology. For some odd reason, that seems appealing too. I don't know why.
That seems appealing to everybody. My little sister's a dermatologist.
Oh, is she really?
Yeah.
Does she love it?
And she lives across the street from me too.
Okay.
But she loves it. Yeah.
Yeah, that's cool.
Yeah.
That's
She's
so
home
fun.
at night, home on the weekends.
Right.
Home at lunch. She's home when I leave for work in the morning. But no, she's actually extremely smart. A lot of dermatology,
they are,
I think,
the ones I've talked to.
kind of tend to be lean towards cosmetics. She's like just incredibly smart and loves like the medical side, which is really cool.
Yeah.
Maybe I'll send her your way.
Absolutely. I would love to if she wants to talk. We should definitely have her on.
She would. Yeah.
Okay, because we got to. Yeah.
Well, thanks for letting me spin the table.
That was a lot of fun.
I was like, guess what? I think I'm going to put him in the hot seat and come up with some questions. And it is hard to do what you do because you're trying to think about. Well, I know nothing about podcasting. What am I supposed to ask him?
Right.
So
that was and again that was harder than I thought it was going to be too. Really, sitting here being asked the questions. So now I kind of have a feel for what you guys are going through. Helped each other out. Dr. Michael Huot, who is an anesthesiologist, board certified medical director at the Pain Management Clinic at Monument Health, and you're also the director.
Yeah, I'm the executive medical director for quality and safety for the whole system. So
God, go take a nap.
What do you do? I know.
Jeepers creepers. That's why you always bring coffee when you do these interviews too.
Right.
Thank you so much, Doctor, for coming in. I appreciate it.
Thank you. It was very good.